I'm Jennifer Sumner. I'm a clinical psychologist, and my work really looks at the intersection of mental and cardiovascular health, including in patients with SCAD. So today I'm going to be talking in some more detail about psychosocial and physical triggers of SCAD. And so despite growing research on SCAD in recent years, the exact causes are unknown. Nevertheless, we think that SCAD is likely multifactorial in nature with a number of potential predisposing factors. And as we've already heard, several factors have been identified that can potentially trigger SCAD. And as we heard from Dr. Sanghavi, in general, it's thought that there's this interplay between underlying vulnerability with respect to the artery and potential triggers that then can lead to a spontaneous tear or an intramural hematoma, so that two-hit hypothesis. And what we see is that intense stress has been identified as a common trigger of SCAD, identified in multiple cohort studies of patients with SCAD. And we see that this can include both extreme emotional as well as extreme physical stress that can potentially precipitate or trigger a SCAD. So what exactly does that look like? That can look like intense distress, like extreme sadness, fear, anxiety that could result from a traumatic experience, a severe stressor like loss of a loved one, a relationship breakup, an extreme workload, or an intense argument like we heard in Vonda's story that she shared today. This also can include intense physical stress like exercise, so heavy weightlifting, other strenuous isometric activities, as well as aerobic activity. And so we think that the mechanism is that stress, whether it's intense emotional or intense physical stress, results in a surge of catecholamines like norepinephrine and epinephrine, which can lead to shear stress on the artery. And it's thought that can contribute in part to a dissection. And this mechanism is thought to be similar as what we see in Takotsubo's cardiomyopathy, as we heard from Dr. Sanghavi, and we're also going to hear more about from Dr. Melissa Wood in the next session. There are some additional potential causes of SCAD that have been identified, even though not maybe as common as the stress triggers identified before. This can include heavy Valsalva maneuvers like lifting heavy objects, straining with vomiting, coughing, straining during a bowel movement, again, increasing vascular pressure, potentially contributing to a tear. The use of recreational drugs like cocaine, amphetamines, methamphetamines. These stimulants can cause sympathetic overactivity, leading to increases in heart rate, blood pressure, and vasospasm. And these can lead to intense shear stress on the artery wall, potentially leading to a SCAD, a tear. We also are going to hear more about pregnancy-associated SCAD later today, but it's thought that the hormonal as well as hemodynamic changes during pregnancy can potentially trigger a SCAD. So for example, the hormonal changes in pregnancy may lead to alterations in the architecture of the arterial wall. So estrogen and progesterone receptors are expressed in the coronary arteries, and related changes during pregnancy may result in a weakening of that vessel wall. Additionally, there's major hemodynamic changes that happen with pregnancy. So pregnancy requires the heart to work harder in order to pump blood throughout the body, and this added strain can put more stress on blood vessel walls, which can then lead to potentially the increased likelihood of a tear. There's also some evidence that hormone-related medications like beta human growth hormone as well as high-dose corticosteroids could also potentially trigger a SCAD, also by weakening that structure of the arterial wall, although I'll note that there's somewhat less empirical support for that class of triggers. So how common exactly are these triggers? I first want to note that triggers are reported by some, but not all patients. So even though triggers are often commonly reported as preceding a SCAD, and especially in the SCAD literature, I do think it's important to keep in mind that not every patient is going to experience a trigger prior to their SCAD that they can identify. I do, though, want to present some prevalence estimates from larger cohort studies of patients with SCAD to get some information about just how common these are. And so first, I want to highlight some data from just over 500 patients recruited across 18 sites in the iSCAD Registry. So in this sample, acute triggers were actually reported by a relatively small proportion of patients with SCAD. So we had nearly 11% of patients who reported an acute emotional stress trigger prior to their SCAD, with intense work stress or an intense argument being the most commonly identified emotional stress triggers. Nearly 10% reported a physical stress trigger. Most common experiences were aerobic exercise and isometric activities. I will note, though, that kind of a larger proportion of patients in the iSCAD registry reported experiencing high overall stress, though, at the time of their SCAD, with nearly 43% of patients. Then we also have a multi-site study of 750 patients in North America, mostly from those Canadian centers that was also talked about earlier today. Here we saw triggers reported by a larger proportion of patients, over 66%. And emotional stress was the most common trigger identified by just over 50% of the patients, followed by physical stress at nearly 29%. One thing I do want to note, though, with these studies of potential triggers of SCAD is that they involve retrospective reporting of these experiences. And as a result, recall bias can be an issue. And this is especially true with a life-threatening event like SCAD, and especially individuals who typically don't present with cardiovascular risk factors. And so it's just important to be keeping that in mind when thinking about the data on triggers and just how common they are. There's also some evidence of patterning of triggers. So for example, in one Dutch registry sample, emotional triggers were identified as being more common by female patients with SCAD compared to patients with acute coronary syndrome, who are also women. So female patients with SCAD, just over around 56%, identified an emotional trigger compared to 39% in the ACS patients. However, in this sample, there was no difference between those with SCAD and ACS in reporting extreme physical exertion as a trigger. Also, as you heard from Dr. Tam earlier, saw that emotional stress may be a more common trigger of SCAD in women, whereas physical stress may be a more common trigger of SCAD in men. All right, finally, let's wrap up with thinking about some of the implications for care. So understanding triggers can help us to guide strategies for risk reduction. And I think patients and providers can work together to really think about developing tailored and personalized plans for recovery. I think the prominence of emotional stress points to the value of strategies for supporting mental health and stress management. I will also note, even if there was not an emotional trigger of a SCAD, SCAD can really impact mental health in a wide variety of ways. We heard from Dr. Wells the importance of, thinking about PTSD, depression, and anxiety in patients. And so I think, kind of the idea of supporting, connecting to, care for mental health resources, as well as just managing stress regardless of their trigger, is important for patients. And then finally, having evidence-based guidance to inform personalized exercise recommendations is also really needed to support patients' recovery, with the goal of avoiding overly restrictive recommendations with respect to exercise and physical activity that might have downstream negative consequences for patients in their recovery, while also still having exercises that are going to be safe for patients. So again, thank you so much for the opportunity to be here today.